at this time. As like most of you probably do not know Erica. This is Erica Brandt. She is the hospital director of our West Vet Meridian Hospital. Um, she has been a wonderful technician for many, many years. She was the one who hired me. It's almost 18 years ago, Erica.
I've made some good decisions in my career.
You did, yes. So she is going to talk to you guys, as you know, about the art of patient care. And so I will pass it off to you, Erica. I will keep an eye on the chat. So if anybody has questions, I know Erica doesn't care if you just unmute and pipe in. But if you want to put any questions in the chat as we go through this, please do. And I will field those to you, Erica, so you don't have to pay attention.
Perfect. I appreciate that. Okay. Does that look good on your end, Brooke? You can see my PowerPoint and everything. Okay. All right. Perfect. Yeah. As Brooke said, I've been a technician for a really long time. I've been with WestVet for over 20 years. Done a lot of speaking as well. I'm a VTS in emergency and critical care. And this is my all-time favorite topic and all-time favorite presentation to talk about. And I just feel so thankful that Brooke lets me do it every year because being a vintage VTS, sometimes you worry that you've said these things so many times and everybody's already heard it a million times, but it's so great to be able to refresh it every year. So just so you guys know, I'm very casual. Please feel comfortable just unmuting or putting something in the chat or raising your hand. So the whole focus behind this presentation is to really think about the way that we approach patients. So I'm going to call out some hard things that we all do. I'm going to call out some mistakes that I've made. I'm going to call out some things that are sometimes hard for us to hear. But really, what I want to do is create a safe space for us to talk about what we should be doing when we're caring for patients and really what that looks like. In my experience of training technicians and working as a technician for so many years, I feel like we get so focused on some of those like big skills. Like I agree, like doing blood transfusions and placing tubes and, doing those types of things are so fun and so exciting. And we think that of that as an advanced skill, but really advanced patient care and the way that we're thinking about the patients and how we're moving them through their treatments to get them home is really what makes a good technician exceptional. If you think about those technicians that you really want taking care of your pets, if your pets were ever sick, the technicians that recognize changes in patients pretty quickly, and the ones that the doctors really rely on or the other technicians really rely on, those are the technicians who understand patient care and are really in sync with their patients. So this is 20 years of rambling, 20 years of skills from a vintage VTS. So I appreciate all of you guys being here and going through this with me. Um, let's see. So advancing my slide. So just so guys know where this came from, I was actually on a committee. The group used to be called the American Association of Feline Practitioners. They've recently changed to the Feline VMA. If you're interested in taking care of cats, if you're interested in, you love cats or you're trying to figure out cats or whatever it is, this is a great group and a great resource for everything cat CE and what we should be doing with cats. So there's a lot of information out there. And so I actually got to help them with their feline friendly nursing care guidelines at one point. And this was one of the statements from the guidelines that I just totally fell in love with. And it helped me change my perspective on patient care and having to work with pets, because I feel like veterinary medicine is a combination of science and art. We often really focus on the science part of it. We think about, learning all of the fancy new technology and learning about all of these things and, all of these really advanced skills, but sometimes we forget about the art of healing and really thinking about our patients and how to make them feel better and how we approach every treatment. So I kind of fell in love with that theory. I also had the pleasure of working with another VTS, Pam Knowles, who did a presentation one time on the human nursing process, and it kind of sparked something in me to really make this presentation. So that's kind of where everything came from, is really thinking about the art of taking care of patients. What we're really going to talk about a lot today is a lot of critical thinking. So thinking about the patient, not the tasks that we're completing. And so I'm going to talk about, documenting things and looking at treatments. A lot of times we don't treat the patient, we are treating the software. And so some of you might understand what I'm saying when I say that, but we approach, back in the day, again, I'm a vintage VTS. So back in the day, we had paper sheets. They started out on the doctor station. They moved to the cages. It doesn't matter if it's a paper sheet. It doesn't matter if it's software. Inexperienced new technicians or technicians that aren't focused on patient care go to the sheet and treat from the tasks on the sheet, and they don't necessarily approach the patient and treat from the patient's needs. And so we're going to talk a lot about that today. What are these individual patients' needs? And I'm going to call some things out when we talk about rounding and we talk about the way that we think of patients. So not necessarily thinking of, oh, that is a GDV, or that is an HDE, or that is a, patient that needs a blood transfusion, or, that's a whatever. Thinking about, this is Fluffy and he lives on a farm and he's never been walked on a leash and he's certainly never been in a cage, and he only eats, dry kibble, and he's never even seen soft food in his life. So thinking about, who is this patient and how am I going to get this patient to feel comfortable and kind of comply with some of the treatments is also really important. And then understanding the pathophysiology of disease, like what is this disease process causing for this patient? How does this patient feel? How is this patient going to respond to treatments is also very important. And critical thinking is definitely a skill that we need to work on. So critical thinking is just as important as placing tubes or learning how to do anesthesia, critical anesthesia, doing our recover initiative and learning how to do CPR. Critical thinking is how we make decisions and how we look at our patients to determine what is best for them and how we're going to move forward with them. So use your critical thinking skills, and utilize them for the patient. So let's see, I'm just going to click through all these. That's kind of annoying. So the nursing care process, and so this is something in human medicine that they actually teach. And I really wish that we would talk about it more in veterinary medicine and actually go through what is the process of nursing a patient. And again, even in tech school, which I haven't been there for a while, but even in tech school, our focus was very skill focused and not necessarily critically thinking focused, and how we're assessing and addressing each patient. So the nursing process, they start with assessment. And assessment, they talk about physical versus emotional. How is this patient doing? Why are they here? How are they responding to treatments? What treatments are they on? So the assessment is really the evaluation and gathering information, which we all do, but we might not do in a structured format. And we'll talk about that. They do talk about in the nursing process, the nurses actually making a diagnosis in human medicine. And I know in veterinary medicine, technicians don't diagnose. And so we're not going to call it a diagnosis. We are going to call it the technician conclusion. And even in human medicine, they're not necessarily talking about that nurse being responsible for diagnosing that patient with something and determining how that diagnosis is going to be treated, but they're talking about what are the expectations of that caregiver? What are the expectations of that nurse for that patient? And so we're going to call it our technician conclusion. So we've gathered the history, we've gathered the assessment. And so now what do we think is going to happen with that patient? What are our expectations for this patient? What are we anticipating that patient is going to need from us during our shift? And what am I going to need to do to take care of that patient? So it's really kind of anticipating the needs and the expectations around what are our goals for this patient. The next thing is planning. So planning is something we often feel like is in the doctor's realm. And a big portion of it is determining what the treatments are going to be, determining when things are going to change. But we should actually absolutely be part of the team when it comes to getting ready and planning things for this patient. You know, being able to assess, is this treatment working? Do I think it's going to work? Is it not working? Do we need to add something else? So the planning part of it, what what do we need to set up for this patient? You know, do I think that this patient is going to need a feeding tube? Do I think my doctor is going to want a feeding tube? And so getting things ready for that, planning for that. Do you have a patient that you're very concerned about? So planning might be something like setting up your crash station, making sure that things are ready for that patient if things do continue to deteriorate, and being ready for those types of things. Or planning might be, we have a giant dog and we have to get it outside. And so it might take two of us, it might take four of us. And what times are we going to do that? What times is that going to be best for the patient and best for the team? So a lot of planning can definitely be on the technician side as well, or definitely in combination with the medical team and the clinical team. Implementation. So this is where technicians really shine, and this is what we are taught to do, is take the planning and the treatments and the diagnosis that the medical team has put together and implement them. So when we learn to carry out treatments, when we learn to give medications and restrain patients and place IV catheters and start fluids and administer anesthesia without being part of the anesthetic plan, we are implementing the actions or the treatments that have been prescribed for that patient. So a lot of us are very comfortable with the implementation and the treatment part of it. I'm going to talk to you about some of the best ways to implement those treatments when we talk about treatments. But this is really where a lot of technicians are focused, is just the implementation part of the nursing process. The other thing I want to talk about a little bit today, after we get through everything else, is the reevaluation. And this is a lot of times where the doctors really need us to support them and help them evaluate what is going on with that patient. So a lot of times in the hospital, the doctor is working up the case, they're planning with us, they're making sure that we're implementing those treatments. And really, it is that reevaluation that they have a hard time getting back to. And so if a patient is hospitalized, they are really relying on us to perform those treatments, monitor that patient, and let the doctor know how things are going. And that's really the evaluation. So just because a patient is on pain medication, just because a patient is on oxygen, doesn't mean that that treatment is fulfilling the goals of what the team has for that patient at the time. You might have a patient who's on oxygen and is still orthopnic. You might have a patient who's on pain medication and still painful, or something still isn't working well for this patient. And it's really, you know, the doctors really rely on us to kind of circle back around and be like, so this is what we're doing. I understand our goals. This is what I'm seeing. And I think we need to make adjustments. And that's really what that evaluation piece is part of in the technician nursing process, and what we should be evaluating. So what else can we be doing? Is it working? And making sure we are communicating with our team, whether that's the medical team or other clinical services. You know, I think we should be doing something else for this patient, or things are going well and the treatments that we are administering are working. So sometimes we don't initiate that step, which is very important. So what I really start with when I'm thinking about patient care is looking at this patient and thinking, what does this patient need from me? What are my goals for this patient, and how am I going to achieve that? The ultimate goal for every patient is to get them home with their owners. And so that's just kind of the understood thing. Of course, it takes, they've got to be eating and drinking and on oral medications and urinating and defecating and all of those things that are normal behaviors to get those patients home. And so a lot of what we do in the hospital is to get them back to a normal state so they can join their household again. But really thinking about how can I get this patient to that state or to that level? Or does this, am I in the surgery and anesthesia department, and what this patient needs from me is for me to come in, be able to monitor anesthesia safely, administer all the drugs with all of the knowledge and things that I have, and recover this patient safely. So really, what does this patient need from me starts my brain into patient care mode. We're going to talk a little bit about, we're just going to start with the assessment and the technician conclusion. So we're going to go kind of through some of those steps. So how do we gather this patient assessment? And there are a lot of different things. Of course, rounds. So who is this patient? So typically, not always are we involved with every step of the patient care process. So we're not necessarily the one going up and greeting the client. We're not the one triaging and taking the history. We might not be the one that did the initial treatments. We might be getting them in the hospital. So at some point, with most cases, we are going to need to get information from another caregiver or from another team member. And so finding out who is this patient is so important. And so here is the first hard truth that I am going to call out. I know some amazing technicians who have a super big chip on their shoulder about giving rounds to other technicians. And really, what I feel like that is a lot of times it's personality conflicts or it's egos in the hospital. And really, rounds should be about patient care. They should be about taking care of your patient. Yes, I can read a record. Yes, I can get rounds from someone else. But really, the best person to talk to me about taking this patient over successfully and not making mistakes and not going back 2 steps in trying to make their treatment successful is the person who's done a great job taking care of them all day. And so we need to be rounding. We need to be talking about patients. We need to be accepting rounds and really learning about patients. So it's so important to get someone's perspective on how this patient is doing that took care of them the entire shift. So rounds are so, so important, and being open-minded and present and engaged during rounds is really important for patient care. History, understanding the history of why is this patient here? And they might have a long clinical history. They might have several disease processes going on. This might be an internal medicine patient who's been sick for a really long time and has a lot of issues. This might be an emergency in a otherwise stable, healthy patient who is there for an acute issue. But it's really important that we know those types of things and know what's going on with these patients so that we can best treat them moving forward. We should be reviewing records. I almost said x-rays. We should be reviewing records, which may include x-rays, but reviewing records is also very important for us to get a perspective on what's going on with the patient. And we might pick up something that someone else has missed. So yes, round should be inclusive of everything that we need, but once in a while, during the shift, it is good to go through and review those medical records and make sure nobody's missing anything in rounds, that we're picking up everything. A new set of eyes on the record is always a good thing. And then reviewing the current medical treatments with a fresh set of eyes, looking at that patient and thinking, are all the treatments I expected here? Are all the treatments scheduled at the appropriate times? And is everything correct moving forward is also very important. Sometimes just getting that second set of eyes in there when you're not as close to the patient, you aren't 10 hours into your 12-hour shift and just thinking, oh my gosh, did my pain medication fall off of the treatment? Or were they scheduled at the wrong times? Or are we missing the one of the treatments? Did we miss the walk, or did we miss a feeding? Are we actually feeding this patient? Because I got rounds that we were. So just putting a new set of eyes on what this patient's actual treatments are, and does that align with what I was told and what I expect for this patient. A technician exam. We're going to talk a lot about the technician exam. Technicians should be performing a complete physical exam on their patient. So it's not just about getting a TPR. It's about putting your hands on that patient, nose to tail, looking for any changes, petechia or swelling or bruising or anything that might be going on with that patient, squinting, anything that you might discover after that patient is hospitalized or something that someone may have missed. Watching the way they walk, watching their conformation, looking at their weights, looking at what their TPRs were in the past, but actually putting your hands on that patient and doing a complete physical exam and knowing that patient beyond the vitals that you just took is very important for good patient care. Expectations. Has anything changed since the last time I interacted with this patient? And sometimes it's as simple as, every time that I've come up to this patient, whether I'm walking by or I'm coming in to do a treatment, this patient has greeted me, has come to the front of the cage or wagged its tail or acknowledged me in some way. And now the next time that I approach this patient, they are disengaged, they're in the back of the cage, they're laying in a lateral position, like something has shifted. If this was a patient who was very engaged and interested in visiting with me when I came in the cage, and now they're aggressive or hiding or, something is different. Are they obtunded now and just a little bit dull and they're not really responding? Like those are quick pick up things that you might notice from that patient's behavior prior to noticing if there were changes in the TPR that may save that patient's life or help us make adjustments before things get really bad. As far as things changing in the TPR, so that's another thing that's very important to notice is what have the TPRs been? We're going to talk about what is normal for the patient and not necessarily what is normal in the textbook, because noticing changes and following trends are more important when we're doing patient care than actually knowing what's normal in a textbook. And we'll talk about why that's true. And then anticipating the patient's needs. So in human medicine, they talk about physical versus emotional. We can also do that in veterinary medicine along the same lines. Like, does this patient look like it's doing better? Is this patient engaged? Does this patient seem like it is feeling better? How is this patient doing? So we can look at things like vitals, pain status, walking outside, eating and drinking, whatever it may be. We can look at ECGs and blood work and all of those things and see if physically this patient is doing better. Scientifically, medically, is this patient doing better? But looking at these patients, and we've all seen those, like think about those hypoglycemic patients that come in, those puppies that come in and you give them some glucose and they were obtunded and looking like crap. And then you give them a little glucose and they sit up and wag their tail and say, thank you, I needed some sugar. It's just like blood transfusions. You're doing a transfusion on a pet and they're pretty dull and they're letting you do everything. And then, halfway through the transfusion, they're feeling better and they're like, no, I would like you to stop taking my temperature now. So just those little types of changes, whether it's that patient's feeling better and now it's harder for me to get in there and do what I need to do, or that patient is doing worse and now they're obtunded, aggressive, painful, whatever might be going on, is really important. And does that match our expectations? So gathering an assessment. So the way that we gather this assessment, we need to start with a physical exam. And we already talked about that a little bit. One of the biggest things that I want to spread to everyone, I want to shout it from the mountaintops, is your exam of this patient and your assessment of this patient should start as a visual assessment before you touch the patient, before you approach the cage. And so there are a lot of things like behavior, there are a lot of things like respiratory rate and effort that changes when the patient knows that you're going to approach them. And so there was a study that sticks in my brain, and it was about dogs that were being assessed for pain scores. And one of the things that stuck out to me was they had a camera on several patients who were post-op. And I think it was a very, something that we would consider a general surgery, like spays and neuters. So they have a kennel full of patients. They just all had surgeries, and they have a camera on them when there's no people in the room. Most of these patients acted painful on camera when they were alone and by themselves. When a caregiver came in, a lot of these patients would engage with the caregiver. So stand up, approach the cage door, wag their tail, be more bright and alert. And so it led the caregiver to believe that that patient wasn't painful when in fact they were, and they were just excited to see a human. And so we see this a lot in dogs. We will see it in cats as well. Like we all believe cats don't have any filter, and however they're acting is how they act. But I do feel like, cats and dogs both kind of mask some of their symptoms when they see people. Or we might see something like the white coat effect, where if a patient is anxious about treatments and they see you approaching the cage, their behaviors might change or their respiratory might change. And so we might see them as, kind of breathing hard and anxious. But if we watch them from across the room, if we leave them alone for a minute, they'll actually lay down and get comfortable. So really looking at that patient, typically across the room, I'm looking at that patient for what their behavior is. Are they looking painful? Are they acting comfortable? And then I will count a respiratory rate outside of the cage. I also do this in the exam room too. If I am checking patients in, I will count the respiratory rate and look at the behavior of the patient while I'm talking to the client, or while that pet doesn't have my full attention on them. So that way I can check and see kind of what their respiratory rate is. Are they acting very anxious? Are they laying down and seeming relaxed? What their respiratory rate is before I do any of their other vitals. So observe from a distance, watch these patients from a distance, and then get in there and do a full physical exam. So nose to tail, look at their abdomen, look at all their toes, make sure nothing's swollen, look for petechia, check their gums, check their ears, check their eyes, like do a full physical exam on these patients. If you don't have time to do it every single time that you're in there with that patient, I understand, but you should be doing more than going in, getting a temperature, pulse, respiration, and piecing out. Like we need to observe how these patients are doing and what their response to things are, making sure they don't have fat foot, making sure that they don't have any other wounds or issues anywhere. And then, of course, vitals. So talking about what is normal for these patients versus what is textbook normal. So for example, say you have a patient that comes out of surgery for a foreign body surgery, and it is recovering from anesthesia, it's doing well, things are going fine, and you start noticing that this patient went from having a temperature of, let's say this patient had a temperature of 100.5. And then you start noticing about 4 to 6 hours later, this patient is 100.5, 100.5, 100.7, 101, whatever. And now all of a sudden you start notice that this patient is 101.5 or 102. So is that technically a fever? Is that technically a 911? No, but pending this patient's history and the fact that we worry about sepsis with these patients, or those kinds of things, I am going to be concerned that that patient's temperature changed 1 degree in 4 hours. Yes, I am going to start thinking about that. Do I need to watch other things with this patient? Having a patient who has changes in their vitals that might not necessarily be abnormal, but it is a significant change for that patient, and it is trending in a negative way towards the concerns that we might have for that patient. And that's what monitoring trends. So everybody says, make sure you understand trends and monitoring your trends. So that is what we are monitoring for, is we are calling out our concerns. So I am worried that this patient might decompensate. What does decompensating look like? So when it's for shock, decompensation looks like hypotension, hypothermia, bradycardia. So if my patient starts trending that way, even as even if the textbook considers those changes still within normal limits, I am going to start watching that patient a little bit closer. So if you have a patient whose blood pressure starts trending down and you're worried about shock or you're worried about decompensation, you are going to alert the team sooner than you would have for a stable, healthy patient who had a high blood pressure and we're not worried about them decompensating. So hopefully that makes sense. Monitoring those trends is really monitoring, is that patient compensating or decompensating, and do we need to know a little bit sooner? If I'm assessing a patient very quickly and when I'm doing kind of a visual vital or a visual scan of all of my patients, I will look for respiration alertness perfusion versus a TPR. And we'll talk a little bit about that when we talk about vitals a little bit more. But one of the things that we also need to do is, just because a patient isn't scheduled for a TPR doesn't mean we shouldn't be interacting with that patient. And so sometimes it's very concerning to me, and this goes along the lines of like, we are often monitoring our software, or we are monitoring a grouping of treatments versus monitoring our patients. So we should have eyes on our patients as often as possible, and we should be assessing them for decompensation. So how is their breathing? How is their interaction? How is their behavior? How is their alertness every single time that we are passing that cage, or at least hourly, versus only doing it when a TPR is scheduled, is important. So additional assessments. Is this patient anxious or agitated? Is this patient painful? What are its behaviors? And do those behaviors align with decompensating or pain or something that I'm concerned with? So there are additional assessments beyond just a TPR that we should be assessing in all of these patients. Okay, so respiration alertness perfusion versus a TPR. So I'm not saying that temperature isn't important. I'm just saying if you have to look at a patient quickly and determine, so this is definitely in triage. I do this if I'm walking by patients in the hospital, if I'm nursing, or if I'm triage or whatever it was on the floor. Like, I am definitely doing this when I approach patients initially. If I come to your house and you're having a party and your pet walks up to me, I am looking at their respiration alertness and maybe their perfusion when no one is looking. So just so you guys know, this is just something that I do, and it gives me a good initial response to, does this patient need something from me immediately? Does this patient need something from the team immediately? Or do we have time to continue with the treatments that we have scheduled? So respiration alertness perfusion. So when I look at the respiration of a patient, I'm just not counting rate. Rate is important, but really what I want to look at is effort. Is it hard for that patient to breathe normally? And how much effort are they putting into that? There's a lot of studies around, especially in cats, what the respiratory rhythm is in cats, and diagnosing them quickly with whatever respiratory concern that they have. So effort, respiratory rate, respiratory rhythm, has something changed? And then if you are not auscultating your patients, if you aren't using a stethoscope and you are just feeling their chest when you're counting respiratory rate or watching their chest expand, start using a stethoscope. Listen to every patient that you can and really start getting familiar with what normal breath sounds are and what abnormal breath sounds are. Alertness and mental status. This is very important, and it's not always easy to learn. And so start experiencing what mentation should look like in patients, and really paying attention to how that mental state changes as the patient does better and improves or decompensates. So this is that magical thing that really great technicians have a good handle on. And mental status can be anything from getting really dull and obtunded, those dogs that start feeling better and they get really obnoxious and they're barking and they're carrying on. These are the cats that start self-soothing and they start purring when they're decompensating. Like all of those mental changes are indication that something is changing in the status of that patient. So being very aware of the mental status is important. Perfusion, this is looking at mucous membranes and CRTs. This is feeling for pulses. If you are not feeling for pulses or comfortable feeling for pulses, start feeling pulses on everything. Go home and feel it on your own pets. Go feel it on your best friend's pets. Feel it on every patient that comes in. Get familiar with what pulses are supposed to feel like, because you can assess those very quickly prior to doing a blood pressure to determine, am I concerned about this immediately? Blood pressures are important, but pulses are very quick. Start understanding what heart rates are normal, what heart rates sound like that are normal. So auscultating these patients are very important if you want to increase your patient care level. Pain. So pain is difficult to assess. Pain can be difficult to assess in dogs. It's definitely difficult to assess in cats, but we can learn this. One of the things that I try to do again is observe the patients from a distance, especially in dogs. Cats will change some of their body position and posture when people walk in, but especially dogs, we miss a lot of pain by approaching them first and assessing their pain. See how they're sitting in the kennel. Are they sitting in a comfortable position? Are they able to rest? Are they laying down? Are they sitting in a weird position because they can't put weight on something? Are they very anxious? All of those types of things. Are they vocalizing? ACE promazine is not a treatment for pain or a treatment for patients. It is a treatment for veterinary staff. And so we need to be very careful that certain breeds or certain patients, we don't just say, oh, they're just carrying on and they're not really painful. Like we need to assess the pain first and deal with the obnoxious behaviors later and really make sure that we're dealing with these patients' anxiety and pain as we need to. And then we want to look at things like vitals. Like if you are painful, if these patients are painful, a lot of times their heart rate will change, their blood pressure will change. We can see physical signs of pain as well, and that will help us determine if this patient is painful. And then we should also be asking ourselves, are these patients, should they be painful? They just had a major surgery, they just had a major trauma, they have pancreatitis, which would be incredibly painful for these pets. Even having some HGE, like having a little tummy upset, like that is painful. And if I was having HG at the level that some of these patients are, I would want a little something for my tummy. So are these patients anxious? Are these patients painful? Do these patients need to just be walked outside and go potty and they would lay back down and rest? Like all of these things we need to make sure that we're assessing and addressing when it comes to pain. So gathering that information. Signs are subtle. Is the patient depressed or aggressive? So behaviors often change with pain. If you have a patient who's pretty aggressive or very anxious or kind of at the front of the cage and now they're huddled in the back, it might be pain. Or if this patient usually was very sweet and now it's become aggressive. When I was first in GP right out of tech school, I thought all blocked cats were just jerks. And now I realize that we were not addressing their pain appropriately and these poor kitties were painful. And it wasn't just, all cats that were blocked were just really awful kitties. We were the ones not taking care of them well. So vocalizing or purring, a hunched position, eye changes. So are they squinting? Are they not making eye contact? Are they looking down? Like these are all signs that patient can be painful. We're not going to talk too much about medications. That's a discussion for another day. Unfortunately, we do blame pain medications for a lot of things that happen to our patients. Hydromorphone is really the only opioid that has been associated with hyperthermia in cats. And so just making sure that we are making good choices for these patients when it comes to pain control and that we are controlling their pain. And sometimes just putting them on a CRI, a fentanyl, fentanyl's a great drug, or giving them a dose of methadone. Methadone's also a great drug, but sometimes for certain patients, that might not be enough. And so it's okay to say, yes, I know that we are addressing this patient's pain, and I understand that this is a medication we're giving. I'm not sure that we are doing enough. I still feel like this patient is painful. Or if this patient is really dysphoric and really hard to work with, or really hard to get treatments done on because it is crazy on its opioid, maybe we should choose a different one for that patient. So I know in human medicine, like all of us have different tolerances to pain medication and pain and those types of things. And veterinary patients are the same. So this is a video. This is a cute little patient here that was brought in after ingesting slug bait. And so being able to address patients quickly and understanding what's going on with them, is this an emergency, and doing that quick assessment. So anything that's a respiratory issue, we can pause that. I don't want to watch that guy tremor the whole time. So understanding if there's a dysfunction or disability that we need to treat immediately. So anything that's a respiratory issue, any concerns that you have that the patient is developing a respiratory issue. So whether this is triage, initial assessment, or hospitalization, watching respiratory changes, respiratory is always an emergency. Concerns about respiratory issues are always an emergency. Bleeding. So we get a little desensitized to bleeding, and there's definitely some instances where pets will come in bleeding from an ear or toenail, and it looks like someone massacred this poor pet inside the exam room, and the owner's very concerned. And it may not be as big of a concern to us, but it's still an emergency on their part. And we need to remember that we get a little desensitized. In the hospital, things like internal bleeding, so watching for things like petechia, or changes in blood pressure, or pale mucous membranes, and watching for things like that are very important to assess bleeding and monitoring any potential for bleeding or signs for bleeding. Seizure activity. Seizures actually don't cause a lot of problems in pets as long as the seizure can be stopped. However, the act of seizuring, especially for the client, is an emergency. This poor little baby here isn't actually having a true seizure. He's actually ingested a tremorgenic toxin, and so he's actually having tremors. So making sure we understand the difference between a true seizure and tremors, and treating those appropriately, is very important. But also understanding for this patient and this client, that is definitely something that they probably want to stop immediately. Trauma. Trauma, until proven otherwise, is definitely an emergency situation. We have some lucky patients out there, but there are definitely some patients who experience trauma. So for example, being hit by a car or attacked at the dog park, and outwardly they have very few signs that they have a lot of trauma going on, but internal trauma, so internal bleeding, organ issues, that types of stuff, we need to be very careful that we are treating these patients as an emergency until we prove that whatever they have going on isn't emergent. Known toxicities are also very important. So if we know a patient got into a toxin, if it is a true toxin that can cause harm, we need to make sure we're addressing those quickly. Anytime a client says that their patient collapsed or arrest at some point, so many times in my career have I heard clients say that they did CPR at home and then the pet was doing better, which these patients are probably having a fainting event, like a syncope event. They probably have some sort of heart arrhythmia or something going on where they didn't have a true arrest, unless I can't even say, I'm recovery trained and all of these things, and I've done a lot of CPR. Doing CPR at home and getting an alive pet to the hospital that is alert is a very difficult task. And so we definitely need to be looking at the source for collapse in these patients, even if they come into the hospital walking and seeming to do fine. If they collapsed at home, if they arrested at home to the point where someone felt like they needed to do CPR, they need to be treated as an emergency. And then any changes in status that happen quickly that you notice in the hospital, or you notice when you're triaging a pet? If they are decompensating very quickly in front of you, absolutely, we need to be treating those as an emergency. The quicker we determine that a patient is decompensating, the better their chances are for success. So, assessment of hospitalized patients, we already addressed a lot of this, but the other thing that we need to gather, other than a full physical exam, a full history, full rounds, is looking at what else this patient has going on, right? Doing an abdominal palpation. Has someone done an abdominal palpation? Do they have a happy tummy? Do they have an unhappy tummy? What is their bladder status? You know, do they have a big full bladder? Are they emptying outside? Like, these are all things that we need to know. What catheters and tubes do they have? Do they have an art line? Do they have a central line? Do they have, just a IV catheter? Where is it actually at? Do they have a feeding tube? You know, what is it that is in this patient that I need to take care of? And are they patent and doing well? Temperature is important. Has this patient's temperature been normal, and has there been a lot of fluctuations? Hydration status. You know, a lot of patients that we have hospitalized are on fluids. And so we need to make sure that we are actually addressing their hydration status. And this is another one of those treatments that sometimes we don't reevaluate. You know, maybe we have a patient in the hospital and we have them on IV fluids and they're continuing to vomit and have diarrhea. Like, we need to make sure we let our doctor know, like, I don't know if the fluid rate is accommodating for the fact that this patient just vomited 2 liters and is blowing out diarrhea all over the cage. Like, maybe we need to reassess our fluid rate, or maybe we have a patient on fluids post-operatively and they are a little overhydrated. And so every single hour, every single time I turn around, I have to change this patient's bedding because it's peeing in the bed. We might be able to slow down those fluids, or we should be slowing down those fluids. So really thinking about hydration status, even if we have fluids in an IV catheter in the patient. Has anything changed? What are the expectations? Is this patient eating? What are they eating? What type of food are they eating? I definitely don't understand the cats that don't want the beautiful collection of things, the baby food and the soft food and all of the wonderful things that I've warmed up in the microwave for them and I'm trying to offer them, and they just want dry, hard kibble. But really understanding what this patient eats, what is their appetite like? Is it improving? Is it declining? You know, what can we do for these patients to get them to eat? Urinating and defecation. When was the last time this patient urinated? Do they have a big bladder? Are they making urine? Those are all important things that we have to. So this is the critical thinking part. Like, we are walking them outside every 4 hours and we're just checking off urinated, not urinated. Well, if they didn't urinate for me, did they urinate for you? And when was the last time that they did that? If they're on fluids, they should be urinating pretty consistently more often. And are they urinating and defecating? So those are things that we need to know and we need to get in front of right away. And then pain. Again, we need to be assessing pain pretty constantly in most of our patients. So now that we've got the assessment, now we know what is going on with this patient, who this patient is, what the treatments are, what our thoughts are as far as why it's there, and all of this information about this patient. Now we gather our conclusion, and the conclusion is, what are my concerns, or what are the issues with this patient? What is its current state? So this is the part where you start thinking about, okay, I understand this patient, I feel like, what are my concerns for this shift? And what am I going to focus on for this shift? So things like, is this patient comfortable? And it might just be beyond pain control. This might be, does this patient has a giant bladder and it's not going potty outside for anyone? Like, that's something that I need to start thinking about. Do I need to pass a urinary catheter? Do I need to walk it outside a little bit longer? Do I need to walk it outside more often? Do I need to see if when the owners are visiting, the owners will take it out? A lot of pets are not walked outside to use the bathroom. Some pets are just let out the back door. And so if you have a short leash on them, They might be a little bit shy about pottying in front of someone, or they don't know that they're supposed to do that on a leash. And so just kind of understanding, is this patient comfortable? Do they have a comfortable bed? Are they laying in a comfortable position? What is their bandaging like? Do they have a comfortable bandage? Is their IV catheter bothering them? You know, those types of things. Are they groomed? Do they have a giant gross fecal mat because they've had, you know, diarrhea all day? Like, is this patient comfortable is kind of beyond even just assessing pain. Is this patient not eating? So if this patient isn't eating, what can I do about that? Do I need to offer something different? Is it expected that this patient isn't eating? Can I talk to the doctor about some, you know, some medications to help with nausea? Like, is this patient anorexic because it's nauseous, or is this patient anorexic because we've been feeding it every 4 hours since it's been here and it just doesn't want to eat anymore? You know, thinking about those things. Is it anxious? Does it have vomiting and diarrhea? Are we addressing that? Like, what can I do now that I've heard the assessment of this patient? What things would I like to address, or what ideas do I have to make this better? We should ask ourselves, are all of the expected treatments on this patient's treatment sheet, or have they been addressed? I expected this patient to be NPO. It's not NPO. I expected this patient to be going outside every 2 hours because it ingested a toxin that does recirculation, like, you know, something like chocolate toxicity or something. Are we not doing that because it ate chocolate so long ago, or what's going on with this patient? So some of those types of things. The other thing that we need to start thinking about when we're doing our technician conclusion is the efficiency of our treatments and how those treatments are lined up. So for example, if I'm really assessing this patient's comfort level, is it resting? Is it eating? Is it urinating and defecating? I have to think about, how often am I going in there and bugging this patient? And I think about this a lot. I was an overnight technician for a very long time, and I always think about the nighttime rest cycle of a lot of patients. And there should be a time where that patient gets to rest. So is this patient stable enough that if I walked up to a cage, and even if it had treatments, I could say, I'm going to let my doctor know I'm going to let this patient rest and I'm going to bump those treatments a little bit? Or is this something that needs to stay on track? Or is this a patient where I think I need to be assessing them actually more often? So really lining up those treatments. And the other thing is, if we are going in and doing a TPR 1 hour, and then we have medications the next hour, and then we have feeding and a walk the next hour, like, when is this patient actually getting to rest? And when am I getting to efficiently move to the next patient? So lining up all your treatments as much as possible. So doing your TPR, doing your feeding and medication, doing your walk outside, and then in between those treatments, making sure you're still observing, still watching that patient, still checking for changes, but really the time that you're in there messing around with that patient, getting them out, moving them around, and not allowing them to rest and heal and feel better, you might want to group your treatments together to be more efficient. Have all of your stuff, take care of that patient, move on to the next one without having to go into every single patient every single hour. And really, it will be more efficient for you and also more efficient for your patients. So planning and implementation, this is not just for the doctors. And I would know we talked about, like, we really rely heavily on the doctors to do this. And that's great. That is what our doctors do. They diagnose, they make treatments, but you should be part of this plan. And not all treatments need to be scheduled. So for example, TLC, extra walks, warming up food, like all of those types of things don't necessarily need to be scheduled. Grooming, you know, those types of things we should be doing just as part of the patient care. And we shouldn't need the doctors or another technician or whatever to do that for us or to think about that. This is the critical thinking nursing care part of what we do. And so thinking about things like, okay, this is the plan for this patient. How am I going to implement this? What is my plan? How am I going to get this 200-pound dog outside? Yes, it's a treatment. Yes, I'm going to implement it, but I need a plan, right? I need a buddy. I need a friend. At this point, when you have the 200-pound patient, none of your other teammates want to make eye contact with you because they know you're going to ask to help lift the big dog. So making sure we have a plan, how are we going to make this happen, discussing what's best for the patient and what we can do best with our teammates. And then what are the solution to our concerns? Like, I'm concerned this patient is decompensating and we might set up a crash station. So thinking about those types of things, this patient is going to go home in an hour and I need to get it a bath. So there are a lot of things that go into planning that isn't necessarily the treatment of a disease or trauma that's happening. So anticipation, preparation, making sure that we are thinking ahead of what we're probably going to need to do for this patient. I have a patient that's going to surgery that is currently on oxygen. And so I need to make sure that I am completely set up before I take that patient out of oxygen and get it induced for surgery. Like, there needs to be a plan for how that patient is going to safely go from being tucked in its nice little oxygen cage, being exposed, and then actually being induced. So thinking about the plan on how we're going to implement some of these things. So the implementation, this is definitely what we do. Planning and implementation, really what we need to think about is what are we actually doing with this patient and how are we going to make it happen efficiently and safely and the best thing for everyone. So what we're doing is planning for changes. We're planning to observe this patient and make sure we're going to see every possible change that might happen so we can keep in front of the bad things that might happen. But we're also celebrating improvements, right? Make sure you're talking to your team and be like, yes, we ate, excited about increases in blood pressure or increases in temperature for those patients that are shocky. One thing that I loved about ER is we were always so excited about even little tiny changes. Like, there's not another group in the hospital that's like, yay, my blood pressure is 25. And it's because it was 20 15 minutes ago before we gave a bolus. And so, those things, make sure you're celebrating the improvements, make sure you're talking to your team. It's not just about this patient is not doing well. It's also about, oh my gosh, I got this patient to eat, or we just went outside and we pottied. Like, I'm going to pull the catheter. I think this patient might get to go home soon. So making sure that we are celebrating improvements and alerting the team of decline, and we are taking action as soon as possible or as soon as we are recognizing some of these changes. So again, we've talked about assessment, we've talked about the technician conclusion or the diagnosis, we've talked about planning. Now we're going to talk about the implementation, or actually how to effectively do some of these treatments. And you guys are so good at this. I would love to have a roundtable discussion where we could just throw out all of our technician tips. I'm going to share some of mine with you. We might have some time at the end, or you can put something in the chat if you guys have good ideas around some of this stuff. But I just want to call out some stuff. The biggest thing I want to call out is be an advocate for your patient. Trust your instinct, trust your skills, do some self-reflection. Should I be doing this? Am I confident to do this? Am I comfortable doing this? And use your common sense. If you are worried about a patient, sometimes we worry so much as technicians that we don't know what is going on. And we don't know how to skillfully say, this is this, and I am concerned about this. And so we don't say anything when we feel like something is wrong. So ECG is a good example. We might not know what that arrhythmia is called. And so we're nervous about calling it out. So instead of saying, I think something is wrong with this ECG, we are nervous about calling that out because we feel like we should have to say, I think this patient is having VPCs and, those types of things. This patient is in ventricular tachycardia. We, as technicians, sometimes just need to say something is wrong and I'm going to talk to my team, and that's okay. So be an advocate, trust your instincts, call stuff out, do it at appropriate times, but ask questions and make sure that if you have a concern about your patient, that the team is addressing it. So understand what this patient's normal is. And I know we've talked about that already, but understanding that if this patient is having a change, even if it's technically in normal range, this is trending towards decompensating for this patient. So increases in respiratory rate, changes in behavior, changes in temperature, changes in blood pressure, even if it isn't at a critical state, if it is a big change for that patient and it is trending in the wrong direction, we need to make sure that we are alerting the team. So one of the things that we have to think about too is how often should these patients be getting these treatments? So one of the things I really want technicians to start thinking about is, does this patient really need its temperature taken every 4 hours? Not a lot of patients need their temperature taken every 4 hours. Or does this patient need to be fed a full meal every 4 hours? So there are a lot of situations where your normal cadence, whatever your hospitalization cadence is, it's usually 4 hours or 6 hours. We need to ask ourselves, how is this patient doing? And how do these treatments align with what this patient needs versus this is just our protocol and what we do in our hospital? So thinking about those things, or this patient keeps peeing in its bed every 2 hours. So I'm going to walk it outside every 2 hours, and then we are going to reassess its hydration status. So just different things like that. Should we really be doing this? Observation is a continuous treatment. So even if your patient only has vitals scheduled or treatments scheduled every certain amount of hours, typically our standard is every 4 hours. So just because that patient doesn't have any treatments in that 3 hours in between doesn't mean you don't need to observe that patient or approach that patient. And I know a lot of us would be like, I'm always in the room with my patient. I'm always keeping track of them. I can tell you, even in the time before cell phones, which now I think it's even worse with cell phones, there were definitely times that in those 4 hours, if patients didn't have treatments or those patients didn't have treatments, those patients didn't get assessed. There were other things that we were doing, whether it was cleaning and stocking, learning, doing CE online, scrolling on our phones, whatever it was, that patient wasn't getting looked at. And I strongly feel like when we are not doing treatments on those pets, we should still be monitoring them. We should still be walking by. We should still be saying hello. We should still be taking a look at the bed. We should still be watching the fluid rate, those types of things. So treatments start outside of the cage. Again, observe, 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 walk by, watch them. What are their behaviors? Are they digging in their bed? Is the puppy eating its bedding? Are they chewing at their IV catheter? A lot of those situations where we have patients that chew their IV catheters or they decompensate, it might be in those hours between when you did TPR and when you actually had a treatment for that patient. So we need to be careful of all of that. So not all treatment should be scheduled. Not all treatment should be requested. Sometimes going in there and looking at that patient, going in and changing the bed, grooming them, those are all parts of patient care and what you determine that patient needs at that time. If it's not scheduled, they still might need to go outside at that time. Like, I don't know that my potty breaks are on a schedule. So just doing what is best for that patient is really important. Understand the alerts and concerns. If you have alerts in your hospital, if somebody else said, I'm worried about this patient doing this, make sure that you understand why we're concerned about that and that you're watching for it. And then when do I alert my doctor and my team? So making sure that you approach your doctor and other people when they are available and able to take questions, but also making sure you're being an advocate for your patient. And if you're really concerned about something, making sure you are bringing that up at a good time with the rest of the team. Organize time with the patient. So sometimes things are so crazy, we really have to go from treatment to treatment to treatment to treatment. And that happens sometimes. So triage even hospitalized cases and even triage your treatments. And so knowing your patients and knowing the concerns and knowing what their treatments are is very important, especially if you have multiple treatments. So if you have a patient and you're worried about let's say you have a cardiac patient and it's on meds. If you have a patient like that and you're like, we are so busy, I don't know if I can do all of these patients' treatments. I might not be able to get it outside. I might not be able to do its grooming. I might not be able to do a full TPR, but it is on cardiac meds. Make sure those meds are given on time. That might be the only thing you get to do with that patient on time. And 45 minutes later, you might be going back in there and doing the TPR. But making sure the critical treatments and the critical patients sometimes are assessed and treated first. And then the things that can wait, do those later in the hour, or if those are the things that get pushed, those are the things that get pushed. Not just treating from the software and starting from the treatment at the top, but really thinking about what treatments and what patients are the most important ones to be on time and going right now, is very important. Line up your treatments and be ready before you start. So there's nothing worse than like going into the cage, getting the patient out, doing a TPR and realizing, oh, I don't have a leash, or I don't have that food ready, or now I need to go get the medications. And so it's very inefficient and it's very disruptive for you and for the patient if you go in to get the patient and you start your TPR and you realize you don't have your thermometer, or you go in and you start treatments and you do your TPR and then you got to put the patient away and then you got to go get the food ready, and then you've got the food ready and then you got to go get your meds ready, and then so you're in the cage and out of the cage and around and doing all of these things. Where if you really look at what are all the things that I can do within this hour for this patient, have all your meds ready, have your food ready, have your leash, make sure you have everything ready for the TPR, make sure you have extra bedding close if you have to change the bedding. So just making sure you are completely ready before you even approach that patient and go into that cage will make things a lot more efficient than going in and taking the patient out and putting the patient back and going and collecting your things. I definitely was annoyed by some of those technicians who were like, oh, will you bring me a thermometer? Have your thermometer with you if you're going in to do a TPR. So tips for respiratory treatments. So like I said, respiratory patients are definitely triaged first for me. So respiratory cases, they decompensate very quickly. They're definitely critical cases for me. So making sure if we need to give oxygen therapy, we need to be thinking about that now, and we need to be thinking about oxygen therapy for that patient anywhere it goes in the hospital. So if we're taking it for a walk, if it's visiting its owners, if it's transferring from its oxygen cage into x-ray or oxygen cage into surgery, like how am I going to keep oxygen on that patient and keep that patient from decompensating in that time? And how am I going to support them? Limit anxiety in respiratory cases. So these cases are very important to have your stuff ready and have everything together before you go into that cage. So going back and forth in and out of the cage, do we need to be doing certain things with these patients? How often should we even have them out of the cage? Is it beneficial to be taking their temperature every 2 hours if it's been normal? Is it beneficial to do their blood pressure every 2 hours if it's been normal? If it's taking them out of the environment that's actually keeping them alive and increasing their anxiety. So really having a discussion with your team. How much stress should we be inducing on this patient, or is it better to just let it hang out in oxygen? Hyperthermia. Sometimes patients get hot when they have an increased respiratory rate or increased respiratory distress. If those patients are hyperthermic, absolutely, we should be monitoring their temperature, but we should be cooling them down and keeping them from getting anxious. So taking their temperature every 15 minutes as we're actively cooling, depending on how hot they are and how quickly we're decreasing their temperature, we really need to debate, is that really something I should be doing? Can I take their temperature every hour? Can I take their temperature every 2 hours? Like, what is it? How can I reduce this patient's stress by still treating them and taking care of them? But yes, a lot of them do get hyperthermic, and we need to be watching for that. And then these patients have to be continually observed. So even if you're not doing every hour vitals, somebody should be watching the respiratory cases pretty closely. Multiple times per hour, you should be putting your eyes on them and making sure that they're still breathing and still doing okay. Making sure respiratory passages, so anything from upper respiratory to tracheotomy tubes to endotracheal tubes, like anytime that you have an airway, make sure it is clean. If you have something who's struggling to breathe and it has a crusty nose, or it has a booger in its tube or whatever it is, like keep those nasal and oral and tracheal areas clean and make sure that we're ready to do that in an emergency. So if you have a patient with a tube in, be ready to have suction to get that out, to change the tube, whatever you need to do. That is part of the planning and the treatment for any of those patients, because nobody should die with a booger in their tube. That's really unfortunate, and we should be ready for those types of things. And then let them sleep. So any of you who have been experienced a respiratory emergency, those patients come into your hospital and they are exhausted. So once we get them in oxygen, once we get them sometimes sedated a little bit, they sleep, and they sleep very hard. And so if you have a respiratory patient that you are treating and you walk up to the cage and they are resting comfortably, you might have to fight me to go in and do a TPR on that patient because they need to rest. And as long as they have been stable and they're breathing comfortably, which you can visually observe, be very careful to go in and disturb that and make that patient anxious again. Like, we really have to be careful of that. And then making sure we have IV access on these patients if possible. But we should be very careful not pushing these patients over the edge with things like placing an IV catheter, taking x-rays, taking a temperature, and doing those types of things. So making sure we have oxygen available when we're doing any of these treatments, and making sure we're doing it when that patient is as stable as possible before we're doing something like that. So this is a good example of orthopnic positioning. So this picture of the black lab I have had in my library of pictures for probably a couple decades now. But this picture just speaks to me so much. So this was a lab who had pneumonia that we were treating with oxygen. So this patient has a nasal oxygen cannula. We were mopping the floor, cleaning up around this patient. He was so sweet and he wanted to say hello to everyone. We just had him out, kind of hanging out with us, whatever, while we were doing his treatments. And I looked at this patient and said, this patient is orthopnic. And everyone thought I was crazy because he's on oxygen. Like, he's on oxygen. We are treating his dyspnea, we are treating his pneumonia, we are giving him oxygen. But if you look at this baby's face, he is distressed. He is orthopnic. He has his neck stretched out. He is in an orthopnic position. He's still engaging with us because he's a black lab, and it's just, people are his thing. And so he's wagging his tail and he's wanting to hang out, but he is having trouble breathing. And so he ended up getting a second nasal oxygen cannula, and he actually took a nap and went to sleep. This kitty is actually in oxygen. The reason why I have the kitty picture is not because we're treating with oxygen and it's still orthopnic, but the one thing that I wanted to point out is it's a lot harder to determine if a kitty is in respiratory distress or orthopnic. So when kitties are in respiratory distress, they're not as obvious as dogs are, but see how this kitty is in a stress loaf, I guess. Everybody knows what a kitty loaf is, right? When a kitty is loafing and they tuck their feet in. So a stressed loaf on a kitty is when they are still in that loaf position, but they push their sternum up off the table and they're very reluctant to put their sternum down, or they're very tense. And so this is what I call a stress loaf or orthopnic positioning in a cat. So it's very subtle, but it's still there. So something you definitely want to watch for in kitty patients. So mental changes, again, mental changes can be the first sign of decompensation, and we really need to be watching that and picking up on that. So if you see a patient who is more obtunded, more depressed, less engaged, vocalizing, purring, just something has completely changed with that patient, we should be going in and checking vitals and keeping a closer eye on that patient, just to make sure they're not decompensating, or if they are decompensating, we're catching it. So we've talked about the respiratory system. So respiration, alertness, perfusion. Again, this is kind of where I gauge my stuff. If we're worried about something with the cardiovascular system or how I'm going to do those treatments, we have to remember what we're monitoring with the cardiovascular system. We want to make sure that the heart is beating and beating appropriately. So we're looking for heart rate and rhythm, but we're also looking at things like pulses and perfusion. Is that blood actually getting to all of the tissues that it needs to get to in a efficient manner? And so that's when those pressures comes in. When I feel for pulses or I do a blood pressure, it's telling me my heart is beating at a good rate, my heart is beating at a good rhythm, and then it's actually getting blood to the places it needs to go. And so those are the quick things that we are checking quickly. And then, of course, ECGs if we're worried about an arrhythmia. And the biggest piece of advice that I can give you is when a patient is bradycardic, that is that patient's body failing when we're talking about emergency situations. If you have a patient who is tachycardic, that patient is compensating. So if we are talking about shock, if we're talking about emergencies, if we're talking about these treatments, these patients, do they need help from us right away? If they are tachycardic, they are compensating for low blood pressure, for bleeding, for shock. They are compensating for pain. Something is going on with that patient and their body is trying to handle it. Once they start becoming bradycardic, they can no longer compensate. And so the emergency gets more dire as the patient gets bradycardic. When they're tachycardic, we might still have time to help them. And so that's kind of the way that we need to think about it. So thinking about a patient that's tachycardic, are they painful? Is their blood pressure low? Are they compensating because they had some trauma, disease, illness, and they're going to start decompensating is what I'm looking at for these patients. Blood pressure, oscillometric versus Doppler. Doppler is definitely the gold standard. We've all heard that. Oscillometric definitely has its place. The machines have gotten a lot better than they used to. They used to be modified human machines that were awful for taking blood pressure on veterinary patients. Just know the limitations of your machines. If you're doing an oscillometric, make sure the heart rate matches up. If the heart rate doesn't match up, we can't really trust that blood pressure. But watch for trends. Is it trending down? Is it trending up? Is it normalizing? Is it doing okay? That's really what we're watching for. And then make sure that we understand how to use the Doppler appropriately. So one thing that I will tell you is that blood pressure constantly changes. So if you've ever done an arterial blood pressure, you have seen this. If you've ever monitored a patient with an arterial catheter in, getting arterial blood pressure, the blood pressure is constantly changing. And so if we are worried about a patient decompensating, or if I take a blood pressure and then you take a blood pressure using a different cuff, using a different leg on a patient that's decompensating, we might get a little bit different numbers. So just thinking about those things, like doing your trends. I should be taking a blood pressure on the same leg with the same cuff and really looking at that patient's behavior and heart rate and matching it up with other things. If I stress a patient out and I'm going in and I'm using a smaller blood pressure cuff and I'm using a different leg and I get a higher blood pressure, it doesn't mean that that patient isn't decompensating. It's I have skewed the results a little bit. So we need to make sure that we understand blood pressure, how we are taking that blood pressure, and how we are monitoring the trends for that patient and how that blood pressure aligns with what's going on with that patient. If you are getting a blood pressure that's not really compatible with that patient being bright and alert as it's trying to drag you through the treatment area, you might want to reassess how you're getting that blood pressure. So make sure we're measuring cuffs the right way. This is probably the biggest mistake that we make, is not measuring the cuff appropriately. It's a little bit frustrating because all patients are probably like a half size. Like we should have 3.5 and 4.5 and 5.5 versus like 3, 4, and 5. I feel like they could always be a little bit in between. And so it's not necessarily wrong that I chose a 2 over a 3 and you probably think it's a 3 sometimes. It's really more about being consistent what leg we're using, what cuff we're using. If we choose to change, just making sure the team knows we change. So whether we go bigger and the blood pressure decreases slightly, or we go smaller and the blood pressure increases slightly, just knowing that we understand that that could be due to the way that we changed doing the blood pressure and not because this patient has changes, but making sure we understand that. Also knowing on what this patient's blood pressure should be so we can alert the team pretty quickly. Do we feel like it's decompensating? Temperature. So I do think temperatures are important. Absolutely 100% think it's important to take temperatures on patients. Sometimes I think on stable hospitalized cases, we take a lot of temperatures that we probably don't need to take, but they are important. If you have a patient and you're concerned about sepsis, if you have a patient and you're worried about shock, if you have a patient and you're worried that their blood pressure isn't going to be normal for some reason, please take it. If you have a stable, healthy patient, you might not have to take their temperature every 4 hours. So be thinking about that. Hyperthermia. Most of the time we see hyperthermia in respiratory cases or cases that we have cooked with the bear hugger. So be really careful with that. We over warm them sometimes and they get hyperthermic. Hypothermia happens with shock. And so we tend to see hypothermia more often with patients. So post anesthesia, patients that are shocky, patients that are decompensating get cold and get hypothermic. So keeping an eye on that, and then avoid burning patients. One of the first medical mistakes I ever made was I was working in a general practice, and when we did dentals, we used a desk lamp that was clamped on the side of the wet sink. And at that time, there was nothing in my brain about don't burn this patient with this light. Like it didn't even register with me. I was like, I just need to see these teeth so I can get them clean. And the patient came back a couple days later with a burn on the side of his face that was from the desk light. And it has haunted me ever since. Like patients get burned, patients get overwarmed, we cause problems with warming patients. So just be really careful. Any patient that has a bear hugger on needs to have temperatures taken. Any patient that has a fluid warmer on, any patient who is hypo or hyperthermic, yes, we need to be monitoring their temperature, but make sure we understand why we're taking that patient's temperature and if we need to be doing it as often as we're doing it. Medications, the number one medical mistake that we are seeing in all of our hospitals is medication mistakes. I have seen amazing, brilliant, awesome technicians that I would trust to do anything that needed to be done on any of my little fuzz heads 100%, and I have seen them make medication mistakes. So we are really trying to work on this. We're trying new protocols, and I promise you, if you are part of your patient safety committee, if your patient safety committee comes out with ideas to help with this, please be open-minded. Please accept these changes. We are trying to protect you because there is nothing worse than taking that home or carrying that on your shoulders as a technician that I made a medication mistake. And a lot of the way that our hospital pharmacies are set up, a lot of the ways that our policies are set up without double checking, it is very, very, taking verbal orders is another thing that we should never do. But we are set up, unfortunately, to make mistakes with medications. And so we are working very, very hard on this. But be an advocate for your patient. Asking you to double check your drugs, asking you to have two signatures on medications is to protect you and to protect the patients from those medical mistakes. It's not about ego. It's not that you're not a great technician. It's that we know you're busy and we know you have a lot of things going on and we want to protect you and protect the patient. Medications, understand the medication that you are given. What am I giving? Why am I giving it? How am I giving it? Make sure every medication is labeled. I will not give a medication unless the syringe is labeled. I won't give a pill unless somebody tells me what they're giving. Like I want to make sure that I don't make any medication mistakes. And in my leadership career, I have had to have some very difficult discussions with some amazing technicians about making mistakes just because we weren't following some of these protocols. It is our number one patient safety concern. And it's not all around the math. I know we all worry about, are we doing math correctly? Are they doing math correctly? Are new people doing math correctly? Like, making calculation mistakes isn't the only mistakes we're making, but absolutely make sure that you understand calculations and you're double, triple checking those. Fluid
Erica,
therapy. Yes.
sorry, quick question. Brittany,
Yes.
in your many years, what do you feel about alcohol and the Doppler crystals? Do you think it does damage them?
So all equipment manufacturers will void the warranty if you apply alcohol. So what the alcohol is very drying to any plastic or glue. And so I don't think that alcohol damages the Doppler crystal, but I think what it does is wear down. There is a protective layer of, I don't know if it's a glue, an epoxy that keeps the crystal kind of in place and protects it from scratches and damages. The alcohol does dry out that compound and the crystal can become defective faster. However, I do think sometimes we have to use alcohol. So if there's any operations people you have to plug your ears for a second, but I do think from a medical standpoint, sometimes we need alcohol to help us find the artery to get a good blood pressure. And so try not to use alcohol, but if you are really struggling with finding that artery and you can't do it with a gel, you can I use alcohol a little bit. Does that answer your question? So yes, it does cause a problem. It will wear them out faster, I think, but sometimes we got to use a little bit. If you can use gel, the gel is better at maintaining the equipment. So that's my take on that. We are running a little behind, so I'm going to go a little bit quick through the rest of this, but fluid therapy. So the biggest thing I have to say about fluid therapy is we have to stop monitoring fluid therapy from the desk chair. And I know all of you are going to tell me that you don't do this and you monitor fluid therapy, but I know in between actual treatments and going in and taking care of that patient that we all sit at the desk and type in that number into SmartFlow, that we monitored that patient at 35 mils an hour and we never got up out of the desk chair. And we will spend hours sitting at the desk and monitoring fluid therapy without ever looking at the patient or touching that fluid pump or looking at the IV catheter. So that being said, when we monitor fluid therapy, the reason why that number is on there every single hour is because that is a continuous treatment. When we are signing off and saying this patient was on 35 mils an hour, we are assuring everyone on our team that that patient, the fluid pump is on 30 mils an hour. It's actually giving 35 mils an hour. It's the right fluid. It's actually going from the fluid bag through the pump appropriately and into the patient and not into the bed. That the IV catheter is patent. They haven't chewed it out. It hasn't become dislodged. They don't have a fat foot. That is what we are saying when we put that number in that square. And so that's all I'm going to say is fluid therapy monitoring is more about just saying 35 mils an hour. Like, we are assuring that this patient is getting fluids at 35 mils an hour. It's a big responsibility. It's a big treatment. These patients need to be getting their fluids appropriately. We shouldn't be giving fluid therapy to the bed. And then all of that. So we will move on. Down patient care. Patients need to be moved every 2 to 4 hours. Sometimes these patients are big. Sometimes these patients are awful to move. Getting them outside, passive range of motion, rotating sides, all of this stuff is very important for that patient. It increases morale. It's going to get them up and moving sooner. It is going to be hard on the caregivers. Don't do this by yourself. Ask for help. Schedule these things when the whole team can come together and do it together. If you're an hour late, we have to compromise with that, but make sure we're keeping them well padded and we are getting these patients up and moving as much as possible. Take them outside, set them in the grass, even if they can't walk out there by themselves. It really does increase morale and help these patients feel better sooner. But make sure you have help and you're discussing that as part of the plan. Yes, I know this patient needs to get outside. I don't know exactly how we're going to do that. So nutrition, when we are trying to feed patients in the hospital, this is very, very important. Some people are so good at this, and I'm really jealous. I was definitely one of those technicians. I could get patients to eat, and then I sometimes had to ask for help. And I'd go, we used to work with a technician named Brandy. She's retired, but she was magical at this, magical at this. And I'd be like, please get this baby to eat. He doesn't want anything that I have. So offer a lot of options. Make sure we warm it up. We should not be giving refrigerator food to any patients. We need to warm it up, make it nice and smelly. Make sure we are offering fresh fruit food frequently if we're trying to get a patient to eat. Don't leave crusty food in the cage. This is one of my biggest pet peeves. Like leaving it in the cage for 4 hours, that patient's probably not going to kind of come back to it. So if you offer it, they don't want to eat it right away, you can leave it for a little bit because some patients don't want to be stared at while they're eating. And so sometimes if you walk away, they'll eat it. But it probably shouldn't be there for the full time. So go back a little while later and take that food out of there. Make sure that the patient is not nauseous. So you will not get a patient to eat if they're nauseous or not feeling well. If you go to treat a patient and they do a hard swallow, if they gag, if they start drooling, that patient is nauseous, and we should be talking to our team about how to treat the nausea before we try to feed that patient again. How often do patients really need to eat? Probably not every 4 hours unless we are really giving small amounts, but we tend to overfeed patients that are eating in the hospital. We need to be careful of that. Sometimes taking the patient out of their cage, so walking the dog first and feeding them outside of the cage, taking a cat, putting it in an exam room, letting them wander around a little bit. Not only does it help encourage them to eat, but sometimes it encourages them to actually use the litter box if you bring a litter box with you. So not all of these patients want to go potty in their bed. And so that's what it is for them. And they have gotten in trouble since they were puppies and kittens for doing those types of things. And they have a urination, defecation, and an eating routine that does not involve doing it laying in their bed. So really thinking outside the box when how are we going to encourage this patient to eat? A lot of times they do a lot better outside of the cage or after they've gotten a little exercise or moved around. Urination and defecation, making sure patients are urinating, making sure patients are defecating. We really need to pay attention to this. The other thing that I notice now is that when we're taking patients outside, we're often scrolling on their phones while they're doing their thing. We need to make sure it looks normal, their posture is normal, they're not straining, that they're not blowing out diarrhea and we're missing it, or something has changed with these patients. So making sure we're watching that. Patient comfort, again, like I said, it's pain, it's anxiety, it's temperature, it's urination and defecation, it's cleanliness. Is this patient clean? I have this awful picture here of probably the ugliest towel we've ever had in the hospital. And I know my team's probably embarrassed that I show this all over the nation. But the thing that I want to get across is being comfortable sometimes for these patients is having some privacy, especially for cats. So providing a safe place and a place to hide is very important to them. And so making sure that we are I understand wanting to see your patient. I understand in the ER and the ICU, like I have to be able to look at my patient, but this is a great example of how we can give them some privacy and still kind of be able to peek in and see them, but that is very important to them. The other thing that I think is really important is if this patient's cage is not soiled, I don't believe that we should be changing the bedding every 12 hours or whatever. If it's soiled, yes, and we need to make sure we are watching very closely for that. So any urine, any food, any litter, anything weird that's on this patient's bed, vomit, old pills, whatever, we need to be looking for that. But if this patient has made this bed its own and it's become somewhat comfortable, if we put it in a new bed or we completely change its bedding and we scrub it down, then it's back to being a foreign area and they have to get comfortable all over again. So make sure you are really paying attention to how often you're changing cages. Yes, they need to be clean. Nothing soiled absolutely comes out right away. Soiled litter boxes, soiled bedding, take the old food dishes out, like keep their cages clean, but we don't need to necessarily sterilize them and start over every single time. Cat tips, give them a place to hide, let them come to you. So reaching in and grabbing them is really scary. Keep their food and litter as separate as possible. No one wants to eat dinner in the bathroom. Making sure they have appropriate litter boxes. If you have a patient who's old, arthritic, post-operative, having those big giant lids to kind of get over when they're sore, they're going to have a hard time getting in those litter boxes. If your patient is laying in the litter box, it's because it's the only thing that they can hide behind. That's why they're in there. So giving them something to hide in, giving them a nice big bed so they can hide in it. They're looking for a place that they can hunker down behind, and that's often why they get in the litter box. And then making sure we're not scrubbing away and sterilizing their cage every single time. With dogs, it's all about saying hello, introducing yourself. Big, heavy patients or patients that are aggressive, put them in a bottom kennel. It doesn't matter how small they are. It's safer for you and safer for them. If they're going to bolt out of the cage, if they're going to attack you, if they are going to be aggressive in any way, or if they're really heavy, even if it's a Chihuahua, if it's a heavy Chihuahua, pick them up from the floor. Be careful putting those big, heavy dogs in those cages. Some of you who are tall might not have a problem with this, but when those cages are kind of like chest height, I'm taller on team. So all of you probably think I'm really tall. I'm not tall. And so picking up those big, heavy patients in a top cage is kind of hard for me and hurts my back. So, and then think about the patients. One of the things I wanted to say about rounds is one of my biggest pet peeves is going through the hospital and being like, okay, this is our post-op GDV. This is what's going on with it. I will always ask, what is his name? Because that helps me think about this patient as an individual patient having individual needs versus a disease process. And so that really helps me kind of focus on, this is a patient, this is an individual, he has a home life. He got in trouble for potting in his bed. He only eats kibble, whatever it may be. He's never been walked on a leash because he just gets let out in the backyard, whatever it may be. But thinking about that patient by his name and not as this disease process really helps kind of open my mind to some of this patient care stuff. We're almost done. Importance of walking. It improves the patient's condition. It actually helps give us a good idea of how that patient's doing, getting them out of the cage and getting them moving. Are they limping? Are they swollen anywhere? Are they lethargic and we didn't realize it because we've only seen them lay down and we haven't actually seen them get out? So walking that, it improves the patient's morale. They're more likely to eat. They're more likely to urinate and defecate. Even with cats, get them out of the cage, take them in a safe area and kind of let them wander around a little bit if you have time for that. And if we can do that safely with these patients, but get these patients out of their cage sometimes. And then even if the patient is down, even if they're not going to walk, getting them outside in the fresh air, into a different area, cleaning them up, all of that stuff will increase the morale of that patient. And then TLC. So you might recognize this beautiful technician taking care of this baby, but snuggling with your patients. Not every treatment should be, not every interaction with your patients should be associated with a treatment. So I heard, it was on a daytime talk show, but I once heard a story about a human neurologist that actually had a stroke, and she went into the hospital and she actually talked about when she was in that phase where she had amnesia and she had the mental capacity of about a 5-year-old while she was going through her stroke. She said she remembers that she could tell just by the way they approached her in the room if the nurse was coming in to do something nice or if the nurse was coming in to do treatment. So she could tell the difference between a nurse coming in to get her food or to check on her or to tuck her in or bring her a new blanket versus the nurses that were coming in to do vitals and do blood draws. And that really changed the way that I go in and see my patients. I always try to love on them a little bit. Even if I have to do treatments, I end and start every treatment with them with saying hello and talking to them and snuggling them and give them grooming, cleaning their faces, taking a little toothbrush for the kitties and kind of rubbing their face, making sure they're nice and clean, cleaning their toe beans, making sure their butt's clean after they've had diarrhea. Like all of that stuff is really good. Also, letting owners visit. These are their babies and these babies know them. Like I can't imagine being in the hospital and not being able to see my people. Or if my fuzz head is in the hospital, like I'm coming in, you guys. Like let these owners visit. It is good for the patients a lot of times. Sometimes the patients get worked up and we can work on those one-offs, but let these owners visit, let them see their babies, and then making sure we're helping with basic behaviors like grooming and those types of things. So time to evaluate. We've done our treatments, we've made our plan, we've got our assessment. Don't forget to evaluate. Just because this patient is on treatments doesn't mean it's working. Just because this patient is on treatments doesn't mean something else isn't going to come up. And that's where you guys come in. Like I'm administering this treatment and this patient hates it and I can't do it. We got to do something else. Or I'm administering this treatment, but I still feel like he's painful. I still feel like he's dyspneic. I feel like he's decompensating, whatever it may be. Or I don't feel like I need to take this patient's temperature every 4 hours. Can we back off on that? Or I don't think he needs a full meal every 4 hours. Can we back off on that? So really evaluating what are we doing? Is it working? Can we make some changes better for the team? Because it needs to be better for you and better for the patient. Again, nursing process, we talked about assessment, we talked about our conclusions, we talked about planning, we talked about implementation of these treatments, and we've talked about evaluation. So all of these things, all of these steps are really important to having great patient care. And I know sometimes it's busy. If it's busy, communicate, triage your treatments. It should always be about the patient, getting help, talking about these patients. What do I need to prioritize? Ask a lot of questions and then be prepared. If you are prepared and you line up your treatments, just going in and being more efficient with the interactions you have with these patients will free up a lot more time for you, where you will feel like you aren't just going from treatment to treatment and bouncing from patient to patient to patient. And it will give you a lot more time if you're planning ahead, efficient, and prepared when you're doing these. When it's quiet, love your patients even more. Go in there and do more snuggles. It should always be about your patient the entire shift. There's cleaning and stocking and all of that stuff that we have the opportunity of doing when it's slow, but go in and love on your patients. They should get extra TLC when you have less patients, and then teach someone else how to do good patient care. Learn about a new disease. Like those are the things that we should be doing when things are slow. And then just remember, the science part of patient care is important, absolutely. And we all want to do the fun things and place the tubes and learn critical anesthesia and do CPR and all of these awesome things, draw blood from a jugular, wherever you are in your career. But remember the art part of it. Get to know your patients, go in and snuggle them, watch for those behavior changes, really critically think about your patients. And that's all I have for you guys.
Thank you, Erica.
Yeah, thank you guys for sitting through my ramblings.
No, this is always such valuable information. I especially love the first half of the critical thinking, and I think that's the biggest missing thing versus the hands-on patient care. So thank you.
Yep, you're welcome. Thank you guys so much.
Yep. And I will have this recording here in the chat. So if you ever want to come back and look at it or show it to any of your coworkers, please feel free to.
Perfect. Did anybody have any questions or anything they wanted to chat about before I sign off? No, it sounds like everybody's good. All right, thank you guys.
Okay.
Bye.